It is my honor to introduce my friend and colleague, Wayne Altman. He's the professor and chair of family medicine at Tufts University School of Medicine. He's been there for 2 decades. He's won like 35 teaching awards. I'm not going to repeat all of his accolades, but there are plenty. But I will focus on a few. Dr. Altman co-founded Care That Matters, a multidisciplinary group of healthcare professionals across the country advocating for pay-for-performance quality measures that are both patient-centered and evidence-based. And particularly in regards to what he's going to talk about with us today, Dr. Altman is the founder of MAPCAP. So MAPCAP stands for the Massachusetts Primary Care Alliance for Patients. This advocates for anti-racist health policy that features an emphasis on social determinants of health, health equity, a global perspective payment for primary care, which results in doubling in our primary care investment. So just so you know, just to give people a little insight into this topic, in America, our average investment in primary care is 5 cents for a dollar. And Wayne is going to share with us some of his innovative work in Massachusetts of increasing that investment. Because if we can double that to 10 cents per dollar, some good data shows that we have a return on investment of 5. So for that extra 5 cents, we can improve health outcomes 5-fold. So Wayne just got done talking to his governor in Massachusetts just before this meeting, and I'm really honored to work with him, and we're excited to learn from you, Wayne. So we'll let you speak, and then we'll have time for Q&A at the end.
Amazing. Thank you so much, Dave. Thank you for inviting me to be here with all of you. I hope that we'll learn from each other, and I'm delighted to tell you this story as I hear you talk about a nickel for every dollar going to primary care, Dave. It feels like our past tense motto in primary care should be a penny for your thoughts. But turns out we might be worth more than that. And it's not even what we're worth. It's what investing in primary care can deliver that this is about. And so we want to tell you our approach and what we've been working on. So we're talking about an optional primary care payment model that we named Primary Care for You, or PC for You. Initially, we were going to call it Primary Care for All, but the senator with whom we're collaborating advised us against the for all terminology because it does trigger certain people in the political spectrum. And so we removed that terminology and we call it PC for You. The overarching goals of this legislation are to decrease health inequities and begin dismantling systemic racism in healthcare by doubling primary care investment in the state and switching to a predominant payment model for primary care from fee-for-service to a monthly prospective payment. What we're working towards is primary care as a public good for every resident of the state, as recommended in the 2021 NASEM report. And you know, in the previous presidential election, there was a lot of talk about Medicare for all, and it's reached everybody's attention. And there are a lot of folks who are in favor of it. I think I'm one of them. And yet it's been hard to move the needle on this. And what a lot of people think as a good large step in that right direction is primary care for all. And so there's a lot of momentum throughout the country regarding investing in primary care. This is a map that shows some different states and the work that they've been doing. And this slide is about 9 months old, and it's already completely out of date. California should have a color, North Carolina should have a color, and soon Wisconsin will light up on this map. And so we started this process almost 4 years ago. It's hard to believe. We got a group of about 20 folks together. We have 4 medical schools in Massachusetts. We had representation from all 4 medical schools, some politicians, some stakeholders, and we sat in a room at our Massachusetts Medical Society. They served us a really nice dinner, and we brainstormed if we had a magic wand, what would we want to do in primary care? And there were a lot of disparate opinions, but the one thing that we all agreed on was a list of what we called the primary care transformers. And stay tuned, I will share that list with you in just a few slides. We also reached out to the Primary Care Collaborative, the PCC in Washington, D.C., who's supporting states across the country investing in primary care. We went to our state's Health Policy Commission to talk to them and learn from them. And just as we were trying to figure out how to move forward with our proposal, our governor, who just finished 2 days ago, proposed a 30% increase in primary care investment. We thought, wow, 30% is not enough. You know, that takes us from 5 cents to 6.5 cents. That's not good enough, per what Dave was talking about before. But directionally, it's excellent. And we were pretty delighted that our Republican governor was proposing this. And so these are some of the details of what he was proposing, which was a 30% increase over 3 years in both primary care and behavioral health. We thought this was pretty fantastic. And we went to the State House and we testified in favor of this, and there was some real momentum. And then some of you might remember there was a global pandemic in March of 2020. And what ended up happening as a result of this pandemic is our focus on doubling primary care investment was joined by a second focus around changing the way primary care clinicians are paid. Because when you have a situation where people aren't coming to the doctor and there's fee for service, that's can be a death sentence to a primary care practice. And it was for many primary care practices. We're going to talk about the pipeline in a moment. And so we put together a proposal, a one-page document with lots of links with evidence, proposing doubling primary care and replacing fee-for-service with a prospective monthly primary care payment. And we sent it around to a bunch of folks, hoping that they would sign their names to it. And much to our delight, those folks sent it around, and we got responses from lots of people, including people we never even sent it to, including deans and CEOs and major stakeholders across the state. And we really had some momentum. And so we put together a task force, and we thought, okay, let's try and make this task force like a small task force, like maybe 7 or 8 people, so we can really get something done. So 26 people were on the task force, and we just everybody needed representation. So it ended up being 26 people. So we divided into 4 working groups where we started talking about risk and quality and employer-based care and PMPM. And we developed a lot of good ideas from those 4 working groups. But what became apparent after the end of the summer working on this task force and these working groups was that not everybody was going to come together and just agree on a solution. Let's go for it. There needed to be a legislative solution. We put together a working group that would get into the weeds. Everyone said, we love your idea, but the devil's in the details. And so we said, well, let's get cracking on the details. We were also advised that no legislation can ever pass without a burning platform. And we thought, oh, our platform is definitely on fire. And, we know about the corrosive effect of fee-for-service on primary care, how it affects both consumers, our patients, and the workforce. We know about the large inequities in healthcare. We know about the exorbitant cost of healthcare. And more importantly, this is really an unprecedented moment in time that requires a new model and non-incremental change to address these issues in healthcare. I don't know about you, but I'm tired of healthcare reform rearranging the deck chairs on the Titanic. We have a gaping wound that we're applying these small band-aids to, and it's not acceptable. It's not acceptable for us, and more importantly, it's not acceptable for our patients. And because of the pandemic, and because of the racial reckoning that occurred in this country in the spring of 2020, This is a once in a generation opportunity to make non-incremental change. And if we blow this, this would be health policy malpractice, in my opinion. I think we have a responsibility to make these changes. And it's really based on the statement that was in the National Academies of Sciences, Engineering, and Medicine NASEM report from or 2021 rather, that said that primary care is the only healthcare component where an increased supply is associated with both improved population health and decreased inequities. And so we can stand on a very high moral ground and talk about this need for non-incremental change. The other piece here is that the primary care pipeline is in deep trouble. Not only do we have not enough people entering the system, we have a lot of people exiting the system, accelerated by the pandemic and the stresses of being in primary care. What's interesting is that this is an old slide from about 15 years ago, but it shows a very fascinating trend. On the top, on the blue line, it shows the ratio of the average family medicine salary divided by the average specialty salary. And in 2008, that was just a hair above 50%. I don't think we're very different right now, okay, in terms of the percent. And also the red line shows student choice into primary care. And you'll see that the student's choice follows the payment ratio. Medical students are smart people. They know math. A lot of people like to talk about loan repayment programs for people choosing primary care, and I'm in favor of them, but they're a pretty anemic lever as compared to changing the ratio of payment for physicians. And it turns out we need to pay people more, and more people will choose family medicine. And in order to pay people more, we have to invest more into primary care. Now, when we market this legislation, you will never find us saying that we need to pay doctors more, because for the general public, that is a marketing message that will never be a winning message. But we hope it will be a side effect of this legislation. Okay, let's get into the weeds for a second. What are we talking about in terms of this primary care monthly prospective payment? Basically, what we're talking about is taking a look at the baseline monthly payment that people are receiving right now, okay? I could use my practice as an example. I am a family physician. I have a private practice with 12 clinicians, about 20 minutes outside of Boston. And our practice, on average, gets about $30 per patient per month. If you take all of our revenue from our patients, some of it is global payment, most of it is fee for service. If you take all that revenue, add it up, divide by the number of patients, divide by 12, we get to about $30 per patient per month, okay? And the idea is in year one of this legislation that we would get a 30% raise, okay, 1.3x, in line with our previous governor's proposal. So that 30 PMPM goes to 39 PMPM right off the bat, no strings attached. In year two, you can increase that. In year three, you can get to double. You have an opportunity to get to 60 PMPM. Your PMPM also will be influenced by quality and risk. We'll get back to that. Here's that list of primary care transformers that I promised you all. Okay, this is all the good stuff, all the stuff that you know is fantastic. And if you had a magic wand, you'd want to have all of this at your practices. Integrated behavioral health, community health workers, addiction care, health coaches, group visits, scribes, medical interpreters, extended office hours, more time with your patients, pharmacists available for consulting. All of these things have evidence to show that they do a bunch of things, okay? And so this is a very busy slide, but let me walk through the columns here. Each of these transformers has evidence that shows that they improve patient outcomes, improve patient experience, improve primary care workforce experience, decrease the cost of a total medical expense for care. And we also assessed how hard it would be, how much work we'd have to do in our practices to implement these things, and how much it would cost our practices to implement these things. And we prepared an evidence-informed score 1 through 5 for each transformer in each of those categories and got an average calculated score. So you can see in the pink column, for example, integrated behavioral health is a 4.1. Community health workers were a 4.2, very high scores. Down below, you have a patient advisory group, which is a great idea, but is not going to have the same kind of impact of integrated behavioral health. So it gets fewer points. And then basically, you take a look at this. This becomes a menu for every practice. And depending on the clinician's talents, passions, interests, depending on the patient population, each practice might choose 3, 5, 7, 10 of these transformers. And however many points attributed to each of those transformers, you get a point total, and then you get tiered into the bronze, silver, or gold tier, depending on how many transformers you have invested in, okay? And so it allows each practice to customize which transformers are most appropriate for their practice and their patient population. And so let's say my practice ended up being in the silver tier based on the number of transformers we invested in. So maybe I get to $50 per patient per month, okay? Based on the number of transformers that I attested to. And so far we're at 50, but then there need to be 2 multipliers for that $50. One based on risk and another based on quality. And of course, we know that the purpose of risk adjustment is to create an equitable allocation of resources. Does it accomplish that? I would argue not right now. And what we propose are that the risk calculation will be based on 2 models. One is simply age and gender bands instead of the typical HCC coding that we're using right now, which involves a lot of gaming and a lot of administrative burden. The Blue Cross Blue Shield of Massachusetts, in some of their primary care products, has already abandoned the DXCG and the HCC coding and replaced it with simply age and gender bands. And when they did an actuarial analysis and compared using age and gender bands with all of the HCC coding, they found out that it worked out to about the same. And, you know, we know if you're a primary care clinician, I'm guessing that you get a talk at least once a year to use the right codes so that you don't leave so much money on the table. Remember, if you have a patient with diabetes and they have renal manifestations, that you need to code not just the diabetes, but diabetes with renal manifestations and neurological this and so on and so forth. And the reason why they come and talk to us every year about it is because doctors suck at this. We suck every year at this. And every year they come and teach us again how to do it the same way they taught us the last year. And I always ask them the same question. How did we do last year? And they said, no, you didn't do very well at all. You guys suck. Okay. And isn't this what you told us to do last year? Why do you keep coming to tell us the same thing year after year? And the only thing that really works is when you hire people, and we did in our practice. We hired a woman named Wanda. Wanda's fantastic. Wanda goes into our charts. We use Epic. I don't know what you all are using, but Wanda goes into our charts and puts a little sticky note about all the different codes that we need to put onto our patients before our visit, and checks that we did it, and make sure that the patients have appointments so that we can do it. And then our risk scores increase dramatically. And so she'll look in the chart and she'll see on an abdominal ultrasound that there was this cryptic message mentioning of aortic dilatation or what have you, and that really didn't matter much to the patient, but it's a risk score. So we'll put it as a diagnosis and get credit for that. And that's gamesmanship. And that doesn't really speak to how complicated the patient is. The other thing is we only deal with medical complexity. We don't talk about social complexity of patients, which matters a great deal. I don't think I need to convince anyone of the importance of social determinants of health. And so there's a mathematician at UMass who developed a score called the neighborhood stress score, where you can use a street address of a patient to predict their social complexity. Not zip codes. Zip codes won't do it. But street address can very accurately, in a patient population, predict social complexity and reward practices who are caring for patients who have a higher degree of social complexity. Our Medicaid in Massachusetts is called Mass Health, and their recent 1115 waiver that they just applied for and received begins in less than 3 months. And when we worked with them in establishing this waiver, we discovered that the work we were doing was completely in sync. Their 5 overarching goals, as you can see on this slide, were completely aligned with what our goals were. And that was super helpful to us as we designed our systems that kind of matched with theirs. For instance, Mass Health has a bronze, silver, and gold tiering system and has transformers that are mostly like our transformers. And then we get to quality measurement. Quality measurement is definitely one of the top 10 things that primary care clinicians like to complain about. And that is a real hassle for people because it doesn't feel like it's meaningful. I think when quality measurement came out 15, 20 years ago, and we were introduced this concept that we're going to get paid more if we take better care of our patients, we like that idea. But I think we're pretty skeptical that it's actually helping us take better care of our patients. At times it feels like it's distracting us or even diverting resources from taking better care of our patients. So in this legislation, we will reduce the number of measures to single digits, select measures that are customized for primary care, that are evidence-based, that are patient-oriented, and promote measures that measure actual patient experience. There's a new set of ABFM measures that were just approved around continuity and comprehensiveness. There's a measure that Rebecca Etz in the University of Virginia Department of Family Medicine developed called the Patient-Centered Primary Care Measure, which is extraordinary, and a measure of patient-centeredness, collaboration, access. We could actually measure in a clinician's patient panel how many times they saw the patient. But in the old world, fee-for-service world, we would say how many office visits. You have 1,000 patients, how many of them had office visits this year? In the new global payment world, we don't talk about office visits anymore. We talk about touches. How many of your patients were touched by your primary care team this year? Not office visits. It's a completely different mindset. It's a completely different approach. Okay, total medical expense is not something we're using as an incentive for primary care physicians. Primary care docs do not have adequate influence on total medical expense. Thus, it is not appropriate to incentivize based on that. This legislation is not an ACO that can influence TME like we're talking about there. So this is an important concept. No deductibles, no copays. If primary care has this amazing superpower of improving health while decreasing inequities, why are we putting barriers in the way of people accessing primary care? Okay, so in this payment model, no deductibles, no copays. And here's the most unusual thing about this payment model. It is executed through a primary care trust. So all the money comes from the payers to the trust, and then from the trust to the practices. Okay? And so if I'm getting $50 per patient per month, and by the way, we're talking about commercial patients, okay? Not Medicaid, not Medicare, just commercial patients. So in my practice, I have 10,000 patients, 1,000 Medicare, 1,000 Medicaid. That leaves 8,000 patients. I'm getting $50 per patient per month because I've opted into this, hypothetically. And so now what happens here is I send a monthly bill to the Massachusetts Primary Care Trust for $8,000 times $50, which is $400,000. And I don't have to fight with the insurance about rejected claims. I don't have to bill hundreds and hundreds of bills every month. One bill for 8,000 patients every month. What's interesting about this model, and before this meeting, I was in a meeting with the state senator who is the chair of the Healthcare Financing Committee, who is our sponsor for this legislation. And her chief of staff said to us, why do we need the trust? Why don't we just have the insurers pay the clinicians and practices based on this model? Why do we need the pass-through? And there's a lot of reasons. One, do we really trust them to do that? Two, it's so much easier. Think about the administrative burden that is decreased by doing it this way. And three, there's law that some of you may be familiar with. It's called ERISA, that basically says you can't tell self-funded plans, employer-based plans, what to do. If you just said, insurance companies, you have to do it this way, ERISA would block it for all the self-funded plans. In Massachusetts, our commercial market is 57% self-funded. So that would be a huge block. But by putting it through the trust, it is a workaround to ERISA law, which is really challenging. And so that's why we have created this model. And so the way the legislation works is you create a board that has a number of people, because it's not ideal to put into the legislation each one of the transformers and exactly how many points you want each of the transformers to have. You want to put some general guidelines into the legislation and let the board put the details together. That's what we were advised. Okay. And so this is the board. It's still a work in progress. We spent the first 20 minutes of our meeting discussing this board today. Okay. How do the funds flow? Participating practices are paid by the trust for commercial patients only. We talked about how the trust will get bills from the practices, but then the trust will bill commercial payers. So of my 8,000 patients, half of them, 4,000 of them, are Blue Cross patients. And so the trust will send a bill each month for my practice to Blue Cross Blue Shield of Massachusetts for $4,000 times $50 and get the $200,000 to pay towards my practice for those patients. We would like to put in this legislation, and we're still working out the language, that national health insurers like Aetna and United Health, as well as third-party administrators, would be required to comply with the requirements of this payment model as well. The fact that the trust would be administered by the Division of Insurance is still up for discussion. That's still to be determined. That's where it sits right now. Here's another key piece of the funds flow. There are certain procedures done in a primary care office, especially family medicine, joint injections, GYN procedures, skin biopsies, vaccines, that we propose should be a small fee-for-service carve-out that would be paid in addition to the monthly prospective payment. If you tell everyone that they're already paid, there will be kind of this perverse disincentive to do those procedures. And there'll be this temptation to say, I'm already paid, so I'll just send this person to derm, GYN, ortho, the pharmacy for vaccinations, etc., instead of keeping things in the primary care office, which is better continuity and less expensive for the system. So we think that small fee-for-service carve-out will incentivize the right thing and keep expenses down. The other thing we wanted to consider is a reimbursement mechanism to reward specialists for formal e-consults and telephone curbside consults. This would help patients, it would help PCPs, it would decrease the cost of the care, and my heart goes out to specialists. If we formalize this, we're asking them to do volunteer work, and as PCPs, we understand what volunteer work looks like in our inbox at the end of the day. And I'm not in favor of asking people to do volunteer work. And so I think a formal structure to pay specialists for the time that they spend doing those formal e-consults would have value. Okay, we did this big town hall. We had, in a Saturday in December, we had 100 family docs come out to kind of learn about this proposal and share their opinions. And what we told them is that 95% of the money flowing into an organization from the trust will go directly to the practices and the clinicians. And they said, yes, that should happen, but you're naive, Altman. It ain't going to happen. They'll find a way to take that money. The systems will keep the money. And that was everyone's biggest concern. So what we've been brainstorming are methods to ensure that that 95% actually flows to the practices. Okay, I'm sure you have large health systems that are really good at consolidating their money and their resources and keeping the money. And so insisting that the algorithms for delivering PMPM revenue must be panel-based, not RVU or productivity-based, is one method. Insisting that folks who are investing or in primary care can't replace this investment with PC4U. They're adding that investment to the PC4U money, okay? And most importantly, by establishing an audit system that asks practices and systems to report how they spent their money and to ensure that the money is going to the transformers, to the practices. This would be done randomly for smaller practices, but mandatory for systems of a certain size. This would be publicly reported, and if folks weren't complying, they'd be forced to rectify the discrepancy or leave the payment model. Okay. This is just to say that behavioral health is a critical aspect of what we do in primary care, and that by having this increased funding in primary care allows us to do things like integrated behavioral health, treat addiction, do case management, increase time, the amount of time we spend with patients. Community health centers. We spoke with our advocacy group for community health centers in Massachusetts, and they said, we like your plan. We don't have a lot of commercial patients, but we do have some. And so if you paid us more for those commercial patients, we'd appreciate that very much. Thank you. But for those patients, we are guaranteed a certain amount called the prospective payment system rate. And you can't go below that rate. We will not take a hit here. And so we, in this legislation, guarantee that that's a minimum payment at federally qualified community health centers. That said, we believe that the PC4U model will be a big raise from the PPS rate, but are happy to guarantee that floor. We also know that community health centers, when you look at that list of transformers, a lot of CHCs are way ahead of the game and already doing a lot of those things. Unfortunately, in community health centers, the way they get paid, number of visits is the very primitive but real currency. And there's a real desire to change this with a more value-based care. Okay. So the idea here is to double primary care investment, but not by just making everything more expensive. The idea is to keep total medical expense flat. And if you're taking a look at the pie, the overall healthcare pie, and you're saying we are not going to increase the size of this pie, but that little 5-cent slice that Dave talked about earlier is now going to go to 10 cents, and we're going to double that slice. Well, now we have to reallocate resources by definition. And of course, reallocation is politically challenging. Okay, nobody wants to take a haircut. And the more people have, the less they like to take a haircut, okay? That said, when you need to get an extra 5% in that pie from the remaining 95%, it's quite a small haircut that others have to take, okay? And so there are a bunch of ways to do this, because the last thing we would want to do is go through this whole legislation and then the prices go up for consumers to pay for the increased primary care investment. That is anathema. That is not what we're trying to do. So how do we keep TME flat while doubling primary care investment? Here are a few ideas. One, we know that there's a return on investment from doubling primary care investment. it may take several years. I will say that there's an experiment going on in California right now where they've done a 1.7x increase in primary care investment amongst a large population. And in less than a year, they already started seeing a return on investment in terms of cost. I'm actually meeting with them at 5 o'clock this afternoon to learn more about that. Another idea to keep TME flat is a cap on the rate of price growth for large hospital systems to offset the increased cost of increased primary care. And so we're not talking about cutting prices for hospitals, but just capping the growth of prices. This was done in Rhode Island and Delaware successfully. You could tax commercial insurance surplus to offset increased cost of primary care. So when the insurance companies make X number of millions of dollars every year, we could tax that surplus. And then, all right, let's keep going. Barriers and how to overcome some barriers. So some barriers, of course, the hospitals may push back if you tell them you're going to cap their rate growth. But 2 points to bring up to hospitals. One, there are a lot of people with barriers to accessing primary care who get their care from urgent care centers or the internet or from nobody. And when you take away the barriers to primary care and you're bringing more people under the tent of healthcare by increasing access to primary care, this will significantly increase downstream revenue for hospitals, but in the right way, okay? And many hospitals lament the cost of underwriting their primary care practices. Our practices lose money and we have to make up for that. Well, they're not going to lose money anymore, so you don't have to make up for that anymore, okay? We think those two things might help get them on board. We might be a little over-optimistic there. Commercial payers, they have told us over and over again, they are in favor of value-based primary care and increased investment in primary care and decreasing inequities. They just kind of want to do it on their own terms. And so they'll need to be convinced that somewhere these increased primary care expenses will be offset, which was what we were talking about on the previous slide. And no doubt employers will be delighted with happier and healthier employees with unfettered access to primary care without copays and deductibles. The only thing they'll need is a guarantee that they don't see their rates increase in their overall health insurance bill. So these are some of the things that we're thinking about. We want to use some funding to support some smaller practices as they work with primary care transformation. It's really hard for some smaller practices to implement some of those transformers, but if you put some of them together in regions and support them with this, it'll make it more doable. And we also want rigorous scientific evaluation of this program for at least 10 years and to have some funding in advance for that. So where are we now? Well, the filing deadline is January 20th in 9 days. And so we are fine-tuning our legislative language. We were able to utilize the lobbyists that we employ at the Massachusetts Academy of Family Physicians to write the legislation. We're fine-tuning that legislation. We're going to file it by January 20th. And then we begin marketing, negotiating with stakeholders, and moving it forward. Okay, I see that there were a lot of questions in the chat. So I'm going to stop share. And then Dave, this is the fun part. Let's chat.
Yeah, so let's do it.
I would encourage people to come off of mute and show their faces if they have questions. Dave, how do you want to read stuff from the chat or have people jump in, or how would you like to do it?
Yeah, just what you said. You know, it's always nice to hear people in real time. So if you don't mind coming off mute and just asking your question in person, that's awesome. If not, just put it in the chat and we'll go from there. And I see Melissa and Jennifer both have their cameras on. So Melissa, we'll start with your question, then we'll go to Jennifer's, and then Jerome had his hand up.
Sure. Thank you so much, Dr. Altman. My question has to do with going back to developing the trust and, concern about, the rising administrative costs in healthcare. And you mentioned that this would be so great for practices, have this less administrative burden, but aren't we just shifting that to the trust, which will need to have a pretty significant amount of people to administer this and deal with all our dysfunctional multi-payer system? So to me, it just seems like a shell game administratively, that you're not going to save money on administrative costs.
Right, that makes sense, Melissa. I think the only thing I would say to that, it is a shell game, and it is a shift of the administrative burden to a government entity, which sometimes rubs people the wrong way. At the same time, when you consolidate this, I think that the administrative burden is dramatically decreased by consolidating it all as one entity, taking care of all the primary care practices, taking the hit for all the primary care practices. But because it's so simple, it's a PMPM, it's not based on 99214s and all the different codes and all of that. It's dramatically simpler. So it consolidates that burden and it decreases that burden. Other questions?
Jennifer.
Thanks, Wayne. It's great to have you with us today. My question, I can't help but I guess compare the fact that we are in very different states, right? So you're in a very blue state and we're in a very purple state. And I was kind of reflecting in my question that I was just talking about the incredible impact and return on investment of community health workers in a very short period of time, with all that evidence that you were sharing with us. And also was just recently in a meeting with a colleague, and we were discussing, but would we not benefit from a policy analyst? So what I was curious about is, while we may be good at aligning with the evidence in our argument, it's still been hard to strategically figure out how to get things at a policy level here. And was curious if you had, as part of your team, a policy analyst who could help think about strategically about how to elevate the evidence and even how to engage stakeholders and which stakeholders, because it's trickier here. So I just didn't know if you had any thoughts or that was part of your experience in galvanizing your amazing team together here.
It's a great question. Two thoughts to share with you. The first is that I believe that there are many concepts in this legislation that have conservative values around cutting cost and being fiscally conservative with an industry that is out of control with cost. Nobody would argue with that. And I think that we can and should really lean into some of the conservative values around cutting cost. The second piece is that we were advised by someone we respect greatly to do some financial simulations, some really elegant, high-level financial simulations to try and predict how the money would actually flow and what it would look like. And I think that's sort of what you're talking about. We agreed with that idea. We worked with, so we reached out to Friedman Healthcare. Some of you may know who Friedman is. AAFP has just contracted with Friedman Healthcare to do a lot of work with them. And there are some amazing people there who are very aligned with these values. And they told us that they know exactly how to do these simulations. Moreover, they know how to market this and how to message this in the right way, and to create slides and images that are digestible by mere mortals who aren't health policy experts, and that can work for people. And for only $150,000, they could do all of this work. And so we worked with Arnold Ventures and then the Commonwealth Fund. In each case, they were very excited about it. We're optimistic that they could fund these simulations, and then the last step, they pulled out. And so we're back to square one on this, and we're working on some different avenues to try and get funding to do these simulations. If you have any ideas on how to fund these simulations, we can go halvesies and try and figure that out. But we agree with you that it would be really ideal to do some simulations and do this work. So we're trying to figure that out.
Thank you.
Jerome.
Thank you for this presentation. As a business guy, I really got into the numbers and intrigued by the trust. One thing I will say, just speaking for myself and my personal experience with our American healthcare system in the state of Wisconsin, unfortunately, I've had to have a number of employers, 4 employers to be exact, over an 8-year time horizon, which for every employer requires me to switch PCPs. And each employer, because I am in healthcare, all had their respective self-funded plans. And so when I saw, the flow of funding with that to the trust, I guess my question is, does this also allow for continuity in relationships with patients, so that if someone were to switch employers because they go from one self-funded plan to the next, but the trust is the same, and so they're getting that payment for that PCP, every month or every year or however the billing happens, that relationship can maintain no matter what happens in that commercially insured, self-funded member's life, so that they can keep that continuity?
Yeah, that's a really good question, Jerome. And I'm not sure if this legislation, as it stands right now, would necessarily solve your problem. That said, as you may remember from one of the first slides, we're working towards a model where we have primary care for every soul in Massachusetts, free of charge. And this is a stepping stone towards that. And if that's in place, then you get paid for your panel by the trust, and the patient in that scenario has the autonomy to go wherever their heart desires. And the practice is incentivized to make their patients happy, treat them like VIPs, take great care of them, and keep them there at their practice, because that's how you get paid. It's an important thing what you're talking about, the continuity piece.
I'm going to offer a little preamble to Melissa's next question. We're the University of Wisconsin School of Medicine and Public Health. By that name, you'd expect a 50-50 investment. That's not what we have. And if you look at a lot of the leadership meetings, there's no advocate often for public health or population health. And so I just state that to preface Melissa, if you don't mind asking your question.
Sure. I know that current investment in public health is lower than primary care. I'm not sure what the number is, but are there efforts to work with public health? Primary care, it seems like working together to realign funding, be more successful, especially at the federal level.
I'm not sure I understand your question, Melissa.
Right now, the investment in public health, so we know it's 5 cents per dollar for primary care. Isn't it like
Right.
2 or 3 cents for public health?
That I don't know. I
It's
know
very-
that we learned in the pandemic that it was woefully underfunded.
Yeah. And so the question is, shouldn't we be working kind of collaboratively with public health? I mean, if we want to, I think that that's another healthcare component that definitely has a return on investment.
I would offer you a thumbs up emoji for that idea. And I will tell you that I reached out to the Massachusetts Public Health Association. They had put their legislative agenda together, and I reached out to their leadership to say, here's what we're working on. We think this is very much aligned with public health, and we'd like to collaborate with you. And I was shocked to get an email reply yesterday saying, no thanks, our legislative agenda is full. Basically everywhere I've reached out around this legislation, Everybody's replied, everyone's interested, everyone wants to talk about it. The first people that replied and said not interested, public health people. Can you imagine? It's shocking.
Jennifer put in the chat, Wisconsin ranks 49th among states in getting funds to local health departments. And so we can certainly do better, and partnership is always more fun. Yawali Anaya is one of our new star faculty members, and she, unless others have questions, we'll let her ask the final question.
Unless there are other questions, yes, I'm happy to. Okay, I'm curious, and this might kind of reflect again a little bit of like a different policy environment, health policy environment, because we're in very different states. But I'm curious, kind of at the high level, how this legislation integrates what the relationship is with your patient population that is uninsured or underinsured. And you mentioned that this is very much geared towards the commercial health plan. And so really thinking about also like how we might think about something like this here in other states. Like, how do you reconcile, how do you integrate, especially for some folks like us in states where we might not have as broad of Medicaid coverage for folks?
Right. So in Massachusetts, our uninsured rate is 2%. And so we're not used to talking about that. It's been that way for like a decade. And so what we're hoping is that this is a stepping stone towards integrating this legislation with what Massachusetts Medicaid is doing, so that they're all part of one seamless system, and that there isn't a separate payment for commercial patients and poor patients. Ultimately, I don't think that's appropriate, and that's a real leveling of the playing field, and it's a real equity accomplishment that we're moving towards. And I don't think this legislation really addresses, in fairness, what you've brought up. And I think that what it does is it creates a model for people to build on. For example, in the Affordable Care Act, aka Obamacare, it got criticized a ton nationally in Wisconsin, and some aspects of it were stripped away, but it's still intact for the most part. And what it did, what people don't realize, I think, is it created a new mindset that everybody is entitled to health care as a right. And even conservative folks who hated Barack Obama, were talking about, don't take my ACA away. I should have health care. And so it created a new mindset. And so hopefully embracing equity and having anti-racist components of primary care healthcare legislation can be a stepping stone towards addressing those additional populations. Thanks for asking that question.
Yeah, Yawali, what I meant to say is we'll give you the final question unless others have questions. I'll pause a little bit in case anybody else has a question. And Wayne, I just want to thank you for being a pioneer in this and for paving a way for us to emulate. Coming from a blue state most recently, I do realize it's easier to do this work when it's less purple, but we learned some wonderful strategies and ideas that will really help us. I worry a little bit because our new tagline for our department is transforming healthcare for all. And if for all is a concerning statement in Massachusetts, I worry that that might be a problem here in Wisconsin, but We'll find a way. So thank you so much, Wayne. It's great to see you, and thank you for teaching us.
Thank you all. It was a pleasure to be with you all.